Thanks a lot.
Good morning, everyone. Thanks for the opportunity to have a chat with you. I just wanted to give you some broad strategic perspective about how Retrieval has contributed to the overall critical care response during this particular outbreak of Delta strain from June onwards. To start off with, once Retrieval needs to get involved in redistributing patients, we've sort of lost part of the game already. So part of our strategy was to encourage the Ministry of Health, who normally doesn't have a real operational role, to be actively involved in some other strategies to get patients to the right place the first time. I'm sure everyone saw pictures of ambulances in Westmead Emergency Ambulance Bay for 8 hours just sitting there. Whilst there were emergency departments and hospitals in other parts of Sydney with intensive care capacity that they could have offloaded at immediately, and driving an hour each way to do that, if you're going to be there for 8 hours, is actually a useful use of time. So via the ministry system performance people, we encouraged the ambulance to have a part in a operational flow centre, which was at the ministry at Reserve Road. And there were people, including David Dutton and other ambulance folk, who were available to help redirect ambulances to emergency departments that could actually offload patients, and also that had ICU capacity to look after them should that be the case. So that was effective. It took a couple of weeks to get introduced into the system to actually start working, but once it started working, it was one useful thing. And you see there's categories on the ambulance matrix for COVID confirmed and COVID suspected, and not taking them to places like Bankstown, Bowral and Fairfield. And each of the LHDs had a similar sort of matrix. Another thing that was done was to introduce into the system an ICU flow coordinator, who's a senior ICU nurse employed by the ministry for the purposes of helping to facilitate ICU bed finding for ICU networking transfers. So these are not the acute upgrade transfers. They still went the normal route through the Aeromedical Control Centre. These are the transfers that were ICU decants for no ICU bed, generally from Western to Eastern or Northern Sydney. And this was a sort of daytime position only, but it was useful in doing some of the legwork for the clinicians in Western and Southwest Sydney who are already blown off their feet by how much work they had to do. This flow coordinator is going to be quite a difficult position for the ministry to actually cease doing, because all the intensive cares and EDs love it, because there's someone else to do the rotten legwork for them for finding a bed for a patient. Ambulance also had a rudimentary triage of COVID patients to mild, moderate and severe categories, to also try and affect transport destination. An ambulance was part of a daily bed huddle that the ministry had, which detailed in excruciating detail ICU capacity for both COVID and non-COVID ICU patients in every intensive care in Greater Sydney. And that was used to be able to help direct patients to the right place to try and avoid double transfers, which we'll see was largely successful a bit later on. So this data is almost a month old now, but from the beginning of the Delta outbreak until 12th of October, Greater Sydney Retrieval had transferred 191 critically ill patients. Latest update as of yesterday, we're up to 225, as there's a trickle of repatriations of return to senders from people. And this is in addition to the normal critical care and pre-hospital workload, which did drop off during the time until things reopened, and then has had a big bump up. About 2/3 of our transfers were COVID positive. Almost all were ventilated, occasionally one just on inotropic support or for some other reason. Of note, we haven't been moving any COVID positive or suspect patients on NIV or high flow. That's in distinction to other places, and I know Hunter Retrieval have moved some COVID positive patients on high flow or NIV. And in Melbourne, just today, our road medical team that's down there was asked to move someone on NIV, and we said, we'll do another patient for you, thanks. The peak of intensive care bed networking retrievals was in early to mid-September, and that was about 2 weeks behind the peak of hospitalisation of COVID patients, which was about a week behind the peak of numbers of COVID patients. And then as of mid-September, there was a reasonably rapid drop-off in the numbers of networking transfers, but at one stage we were getting up to 9 and 10 networking transfers a day, and that's with 4 road teams on, 2 day, two surge, covering the afternoon and evening, and they were all reliably knocking over 2, sometimes 3 jobs each if required, and they were mostly road transfers. The vast majority were by road, some were by helicopter and a couple by fixed wing. A lot of the helicopter ones were to places like Wollongong and perhaps Gosford, and even John Hunter, one of them, as a decant transfer. But most of the transfers were actually from Metro to Metro Sydney, just different destinations in there. 3/4 of the transfers were from an ICU and about a quarter from an ED, and a couple from operating theatres or recovery rooms, which were using those areas as surrogate ICUs. And we'd moved 30 patients on ECMO and another 10 for the purpose of initiating ECMO when they got to the receiving hospital. I'll say more about this a little bit later, but ECMO during COVID has been a little bit disappointing for all involved. The outcome's nowhere near as good as during the swine flu pandemic. That's just a graphical representation of where patients came from and how we moved them. There were sort of 2 phases to the decant, and you'll remember that southwestern Sydney and then western Sydney quite rapidly after were the 2 sort of focuses of community transmission. And so during the first phase, we were moving patients out of those areas to areas that were relatively close, so places like Concord and St George for patients from Liverpool. And then as the community outbreak spread, some of those places that we'd been using as receiving hospitals then got themselves inundated by local community transmission, and Concord and St George in particular started out as receiving hospitals for some of these transfers and ended up as referring hospitals for these transfers, which made it a little bit difficult and caused a couple of double decants, which we've been trying to avoid. We did move a couple of patients out of Dubbo and Orange, and even though the numbers were small, because those places only have a few ventilated patients at any given time, the overall effect for them for even moving one long-term ventilated COVID patient out of their ICU was quite significant. And we were in daily contact with places like that to see whether we could help, and we actually had to cajole them into letting us move some patients for them. There's a very strong sense of, we can cope ourselves. These are our people, which is really good. But if you're overrun and you can't staff the place properly and your models of care might even be changing because of it, then moving 1 or 2 patients can take a lot of stress out of a regional ICU. We did have a deliberate policy of avoiding transfers back into hot zone hospitals, even if they said we can take patients. So at our daily bed meetings, some of these places like Westmead and Liverpool were saying, yeah, we've got capacity to take 2 or 3 patients, and we would just ignore them because they had, at the peak, 180 COVID patients on their ward, which reliably are going to cause a couple of MET calls a day and a couple of intubations and ICU transfers. So we really wanted to avoid double handling anyone if possible and trying to limit the pressure on these hospitals, even though they said we've got a few spaces, we're just going to leave those spaces for your internal patients because we know you're going to need them. This won't surprise you at all. The referring hospitals, Liverpool was the champion, but Westmead and Campbelltown not far behind. And as I said, Concord comes in 4th, even though it was initially a receiving hospital, and it does pretty well in the receiving hospital numbers as well. Some of the referring hospitals, in particular somewhere like Concord, were slower than others in allowing NIV and high flow on the wards. So Concord in particular started off with NIV and high flow only in intensive care, whereas places like Westmead quite quickly were using ward NIV and high flow. So that limited Concord's capacity, and there was a week or two there where they wanted to transfer every intubated patient out of their ICU to have room in their ICU to keep every non-invasive patient. So that caused a bit of a challenge at times. The receiving hospitals, again, won't surprise you. Those in the sort of east and northern Sydney were the ones that were able to soak up most of the patients. A particular call out to Hornsby, who batted well and truly above their weight in receiving lots of patients. At one stage, they received so many that it actually got themselves into strife, and we had to decant some patients out of there as well. But it really showed that the intensive care community, like a lot of systems in times of stress, will band together and help each other out, more so than happens during normal BAU types of activity. We're now up to 9 patients that we've transferred more than once, and looking at those 8 initially, 4 of them were initially for upgrades of care followed by a decant, so 2 to an ECMO hospital, and then the actual ECMO hospitals of RPA and St Vincent's ended up being overrun with so many ECMO patients that we had to decant patients out of there, including 1 or 2 ECMO swaps where some of the tier 2 ECMO hospitals like North Shore, Westmead and Liverpool, if they wanted a patient to go to St Vincent's, say, for VA ECMO, and it's a little bit more difficult to look after at those tier 2 sites, they would swap a VV ECMO patient from St Vincent's for one of those. So we tried to avoid those as much as possible, but occasionally there was no way around it. Another 2 were initially decanted somewhere and then required ECMO. It's difficult to predict which of those difficult to ventilate patients are going to be ending up on ECMO and an ECMO candidate. There were some bariatric patients who normally wouldn't fit our normal ECMO criteria who ended up on ECMO. So again, working out whether an individual ECMO centre is actually going to offer ECMO to a patient like that is pretty hard to predict. We had 2 double decants, and they were when places like Concord and St George, who'd initially received a patient, then had to get rid of a patient. And we tried to pick the most stable and, if possible, a de-isolated non-infectious patient to move. And there was one poor patient who moved 3 times, but 2 of those were for upgrades and then 1 was for a decant. So for over 200 transfers, around 8 patients or 9 patients moving twice is probably a reasonable sort of outcome. We're not aware of a death or a critical incident during a transfer, which is a real compliment to all of you who actually did the transfers. And we're not aware of a retrieval healthcare worker with a work-related infection as well, which is a good outcome, I think, as well. Just a little bit of information on how the intensive cares have fared during the time, and this is aggregated sort of Greater Sydney ICU data. So as you can see, the peak of our ICU occupied beds happened around about 21st of September, where we got up to around 612 patients in ICU on a bed base of around about 540 normal ICU beds. So 70 ICU patients were being cared for in places that don't normally care for ICU patients in that geographical location. A lot of ICUs opened up surge pods, which may have been in either a spare ward or a recovery room or places like that. And some ICUs actually had to start changing their model of care away from the 1-to-1 nursing to 1-to-2 nursing of a specialist ICU nurse with assistance from other nurses. And a lot of the ICUs used both nurses and physicians who normally don't work in ICU. as, if you like, extenders of care. So at places that I took a few patients to, like Prince of Wales, they were using anaesthetists as, JP technicians, and there were nurses from other wards in the hospital who had come to help as well with other types of non-specialist sort of nursing care. The ventilatory status at the bottom there in the blue are the ventilated patients. High flow is the orange, and then the light blue is the non-invasive ventilation. And you can see that the numbers and the use of both non-invasive and high flow came down later, and I suspect that's as clinicians developed a better feel for who's going to end up ventilated anyway, rather than decreasing amount of patients who needed it. This just reflects the same thing, and in the red you can see the increasing numbers of ECMO patients which follow on after the ventilation. So the average duration between a patient being diagnosed with COVID and ending up on ECMO was about 17 days, which sort of fits with their incubation period and then their deterioration sometime around day 5 to day 10, a couple of days of ventilation, working out that it's not working and being offered ECMO. We peaked at 25 or 26 patients simultaneously on ECMO in early October, and that was at the stage where we were doing some ECMO swaps with the different places. And each of the tier 2 ECMO facilities, they often had 4 or 5 ECMO patients each, so North Shore, St George, Liverpool and Westmead mainly. And that's a real struggle because the trained nursing staff to look after those were often insufficient, and if you added a furlough from a staff exposure, which was quite frequent in some of the ICUs, it just pushed some of them over the edge at the moment. In the public system in New South Wales, we actually have around 50 ECMO machines, but some of those are under the auspices of the cardiothoracic surgeons who didn't lightly offer to give them up, as they anticipated that when surgery reopened, they didn't want a long-staying COVID patient still on ECMO stopping them from doing surgery because the machine was used. Private ICUs also have quite a few ECMO consoles that could have been called upon if necessary, but fortunately we didn't get to that state. Consistently, we had between 40 and 50% of the ICU patients were actually intubated and on mechanical ventilation, and the absolute numbers, as you know, have been dropping recently. Interestingly, New South Wales counts a patient as a COVID ICU patient regardless of whether they're still infectious, whereas in Victoria, after 14 days, they dump you off the COVID list because they consider you non-infectious and you're then a non-COVID patient. So it sort of skews the data and the comparison between places by doing that. And not surprisingly, the non-COVID ECMO business decreased a little bit because there was not very much elective surgery, including cardiothoracic surgery, going on, which is one of the main contributors to the non-COVID ECMO load. Interestingly, you can see from this graph that even though we substantially reduced our number of non-COVID ICU patients, we didn't really change the number of non-COVID ventilated ICU patients, which means that we were probably successful in removing some of the sort of fringe patients that end up in ICU that may or may not have actually needed to be there. You know, the septic patient on a very small dose of inotrope, or someone there post-operatively who is there for a babysit and a look overnight rather than for actual interventions required. Again, this nicely shows that phenomenon with the number of ventilated non-COVID ICU patients remaining fairly static despite those numbers coming down. Towards the end, after the peak came off, a lot of the hospitals that had received patients from out of area were keen to repatriate them back to where they came from. And there's probably a little bit of self-interest in there in being able to, take the stress off their own staff, maybe restart surgery earlier. But getting patients back to closer to their families where they can visit, because families were having to travel a long way, and a lot of the long-staying ICU patients with COVID pneumonitis and were going to be a long wean. So families travelling a long way to actually see their relatives, is obviously a very difficult thing. So we had a system-wide process for how that would happen, and like the system that we had for the actual decants during the peak of activity, we wanted to make sure that this didn't interfere with our normal business, if at all possible. As we opened up in mid-October, we started to see a huge pre-hospital workload, as well as some elective surgery coming back into hospitals, and that was increasing the non-COVID workload. And it actually became much harder to find a non-COVID ICU bed than a COVID ICU bed. As we're moving on now and the numbers of actual COVID patients in ICU are substantially decreasing, the problem in some ICUs is if they're not geographically well set up to cope with that, the separation of COVID and non-COVID patients into a so-called dirty and clean ICU becomes very difficult. And health is perhaps looking at a system whereby some hospitals and ICUs that are better set up to cope with that try to selectively take more of the COVID ICU patients than some other places which geographically might not be well set up for it. So there'll be more on that as it comes to light. That's all I've got to say. Happy to take any questions from anyone if there are any.
Any projections on post the microphone, sorry. Otherwise it gets hard for everyone here.
I was just curious, is there any projections in relation to, the post 80 and 90% volume of double vaccination in relation to like the next peak, and any planning around that you're aware of? Just curious.
Yeah, so the ministry puts out projections which are up to 90 days, but the projections are based on the best assumptions that you can make at the time, which is getting more and more difficult to do. As you know, in the sort of New England area, and I suspect in other regional areas, there will be small outbreaks, but none of them at the moment are projected to actually break any particular region by overwhelming it. So New England, mid-north coast, Murrumbidgee and the Albury area are probably the focuses at the moment, and we've still got some surge resources there as far as an extra fixed wing at Dubbo and our extra medical team with the helicopter sort of at Tamworth/Dubbo. At the moment, the best guess is the actual numbers of cases per day may not get beyond 300 or 400 a day, but it's really difficult to know what's going to happen. We've hit the 90% double vax rate, and if we can mop up the 5 to 11-year-olds, if ATAGI decides, ATAGI are going to wait for the US experience of what happens with children and use them as guinea pigs. And then if there aren't any significant side effects, then I think we'll go ahead and vaccinate our 5 to 11-year-olds within the next couple of months, hopefully before school goes back.
So it'd be true to say, though, that the predictions from Ministry didn't come true, which is good.
Which is good.
They were predicting things to be peaking in late October, early November. In fact, things peaked much earlier and tended out nicely. So, but either way, you can see that we've all had to work ridiculously hard. Every single COVID transport is incredibly painful and difficult, then it's more high risk than our normal work, takes longer, the interfaces in hospitals are hard, repeatedly the whole time, and I just want to say thanks to everyone for their hard work, because whilst other people are worrying about their sourdough, we've been working twice as hard as ever.
And those efforts are well recognised by the ICUs and the EDs and the ministry deputy secretaries and secretary all realise the extent of what we've all collectively done. You know, these ICU patients are 10 to 14 days length of stay average each, and we've moved over 200 of them. So we've done a colossal job in redistributing patients to where they can be cared for, and there were only a couple of ICUs that needed to change their model of care to look after patients. So we've been able to avoid a lot of that, and I think that's avoided a lot of mortality and morbidity. Just one last thing I forgot to mention. The mortality from ECMO has been getting worse since the pandemic started, and that's an international as well as an Australian experience. The mortality overseas and here in early to mid last year was around 25, maybe 30%, so a very good survival rate of 70% plus, which is similar to the swine flu pandemic in 2009. And the survival has now gone down to about 40%. 40%. And no one actually quite has worked out why. It's whether with vaccination we're now seeing a different cohort of patients in ICU who have more comorbidities and end up starting off behind the 8 ball even before they get COVID, despite having been vaccinated. It's a bit hard to know. Thanks.
Yeah, good question. There's a couple of questions that come to the WhatsApp group. One, I think Alex is asking, if we ever have to do this ramp up of ICU capacity again, how best to do it, what lessons have we learned? Obviously it's not our job to ramp up ICUs, but New South Wales Health had a very, very clear pathway of surging, which did not necessarily seem to come to fruition.
Yeah, I think that reflects the fact that no one's ever done this before and everyone was making it up as they went. Certainly redistributing patients to the right place the first time could have been done perhaps a little bit earlier. The other thing that health had thought might happen was that we might be able to actually move some staff from one location to another rather than move patients, and that proved incredibly difficult for various reasons. A lot of the private ICU staff who it was thought were going to be able to be moved to a public ICU to help look after COVID patients either didn't want to go or had already found themselves a 9-to-5 job in a vac centre, so they didn't have to go. But people didn't want to be transferred between LHDs or even within an LHD, and the place that would have been donating some of those staff was also not keen to let them go because they didn't know what was in the near future for them as well.
Was the bit that didn't happen? You mentioned, Carol, about the bit that didn't happen with the ICU, that they didn't surge at their own place enough individually, or was there any other greater plan around any particular ICU surging more than others?
I think the issue is they kind of left to their own devices. How much surge they did, they were prompted to surge, but maybe they were very slow to and didn't really have a place to surge to, or didn't have the staff to surge, or then their staff got furloughed because they were contacts. So the whole host of things got in the way of the planned surge, such that we only kind of surged. You mentioned sort of 60 to 80 beds in the whole state. We didn't double our capacity. Well,
that's all we needed to surge to. There was certainly capacity to surge to more than that. But some ICUs and the hospital's physical setup was more conducive to opening a pod here or there, and other places, perhaps some of the older style built hospitals weren't as easy to manage in that regard. We certainly did have very regular meetings. There was a daily ICU bed and capacity meeting, which I went to every single day for the whole outbreak. So the ICUs were well aware of who was coping or who was not, but as you mentioned, there was left to some extent up to the individual LHDs and ICUs as to how quickly they ramped up, and some ramped up more quickly than others. Others were slower to decrease their elective surgery. So, for instance, Hunter New England hasn't changed their elective surgery at the moment, to my knowledge. Whereas in some of our LHDs, we perhaps could have done that earlier. Also, the retraining of staff from outside of ICUs to come and work in ICUs, that happened last year. And those people very quickly forgot a lot of those skills and weren't, if you like, retrained in time for them to come across as quickly as could have happened.
It seemed like, although there was a sort of retraining of staff, that one of the big things was that held back the surge was the changing of staffing models, even, particularly on the nursing side. And was there any push at a state level or direction around when they should sort of change, be it ratios or number of actual ICU nurses?
Yeah, there was an oversight at the ministry statewide level of what was happening. A lot of ICUs, understandably, were reluctant to change their model of care because they perceived that as decreasing the care that they were providing. So it was one of the last things that they were willing to do. And we probably moved some more patients than we perhaps could have if they had changed their models of care earlier. Some places didn't need to do it at all, but particularly the places in southwestern and western Sydney did. And the ones who did that earlier sort of fared better as far as coping with the patient volume that they had.
And then one final question was from Brian, who was kind enough to lead our Dubbo and then our Victorian response. When's he going to go to Queensland?
Ask Anastasia.
I just want to know, what are the key learnings, do you think, from this, and how are we going to move forward in a more conducive manner?
Yeah, good question. So for those at home, the question was, what can we learn from this current response and moving to the future?
For me, one of the main things has been to see what is actually possible when all the players get together with good meaning to achieve an outcome. So the ministry, for example, isn't normally involved in operations. It sort of oversees rather than helps direct. They were involved to some extent in this case, and it was actually a positive thing. We're also seeing what happens when everyone bands together with a common purpose, which I wish happened more during normal activity, that we're all sort of nicer to each other and more cooperative with each other. But I hope there's some long-lasting sort of effect from that in the way that we all get on and deal with each other and try and help each other as much as possible.
Excellent question. Yeah, I think there'll be lots of learnings, particularly ministry level. But Retrieval is kind of business as usual, and we worked hard. Like we always do, we work harder. And what we normally do is prepare to look after sick critical care patients in a safe manner, and that's what we did more of. So there are lots of little micro learning points that we'll transmit. So I'm speaking at MedStar's Clinical Governance Day next week. I'm trying to steal some of your slides.
Yeah, no worries.
Thanks everyone. We're going to have one more question.
In terms of nursing staff, was there not a pandemic response team? I would have gone and done ICU shifts had there been a global kind of request.
So there were plans if required. On two stages. The first, particularly if a very small place like Broken Hill became inundated with patients, as could have happened with the Wilcannia outbreak, there was sort of a two-step plan to initially have some critical care staff, and particularly from Retrieval, as sort of the rapidly available shore up the fences 24 to 48 hours, whilst that sort of further flying squad, if you like, was being mobilised. But fortunately, it wasn't actually required at any stage. But yes, there were plans at a statewide level to do that if necessary that you didn't hear about because they weren't enacted.
I guess that's my concern going forward. Like you see in the UK, you've got assistant nurses looking after ventilated patients and then one registered nurse to 15 in ICU. Those are the concerns that I have moving forward. Is that the kind of model that we'll get to?
No, we didn't get anywhere near that. The worst we got to in some intensive cares was a sort of one qualified intensive care nurse to 2 patients, but they were more the ICU2 type patients, so what we call the HDU, usually a non-ventilated patient. So in effect, we didn't greatly change our model of care at all.
Excellent.
Thank you.
Thanks a lot.
Cheers.